Hello, I'm Manoj Karmakar. Welcome to ISSPS TV. In this next video, Dr. Ke-Vin Chang from the National Taiwan University Hospital in Taipei, Taiwan, is going to be discussing with us how you can identify the small peripheral nerves of the brachial plexus, particularly the suprascapular nerve, the dorsal scapular nerve, the long thoracic nerve, and the thoracodorsal nerve, as well as the intercostobrachial nerve. If you've been enjoying our videos, do remember to subscribe so that you can get regular notifications of any future uploads. Now enjoy the upcoming video.
So thank you, Professor Kamaka, and it's my great honor to be the speaker of ISSPS 2021. My topic is ultrasound image to identify the small peripheral nerve of the upper extremity. So the following are the nerve I'm going to cover, including long thoracic nerve, thoracodorsal nerve, dorsal scapular nerve, intercostobrachial nerve, and the suprascapular nerve. So regarding the first three nerve, the long thoracic nerve, thoracodorsal nerve, and the dorsal scapular nerve. The nerve will be covered in our in the article that we published in 2017. As you can see, Professor Kamaka is also the author of this great article. So the article is open access. So if you are interested in how to scan those nerves, you can refer to this article. So the first nerve I'm going to address is the long thoracic nerve. Long thoracic nerve receive fibers from C5 and to C7 nerve root, and it goes through the costal clavicular space and then reach the lateral trunk, and then it innervate the serratus anterior. So if you want to scan the nerve at the cranial, at the cervical region, you can find the nerve pierce the middle scalennic muscle. At this region, there is another nerve that pierces the middle scalennic. That one is the dorsal scapular. So through this cadaveric picture, you can find the location of the dorsal scapula is actually cranial to the long thoracic, but both nerves pierce the middle scalennic. So sometimes when we scan both nerves, we get confused. So if you trace the long thoracic nerve to the truncal region, you can find that the nerve is besides the artery. The name of the artery is the lateral thoracic artery. And then you can find that the long thoracic nerve is on top of the serratus anterior. So if you want to trace the nerve at the cervical region, first, you put your transducer posterior to the sternocleidomastoid muscle, and then you can find that this is the superior trunk, and the long thoracic nerve will emerge from the posterior aspect of the superior trunk. And then the long thoracic nerve will enter the middle scalennic muscle. So if you move your transducer more distally, you can find the nerve will travel over the supraclavicular fossa. At the level of the supraclavicular fossa, you can find that the long thoracic nerve is embedded underneath the superficial fascia and of the serratus anterior. And the position of the long thoracic nerve to the brachial plexus is the same as when you scan it at the level of the interscalenic level. So you can find the long thoracic nerve is posterior to the cord level of the brachial plexus. And if you move your transducer more distally to the infraclavicular level, you can find that the long thoracic nerve is still posterior to the brachial plexus and on top of the serratus anterior. And if you move your transducer more distally to the truncal region, you can find the nerve is besides the artery. The name of the artery is the lateral thoracic artery. And here we can find the long thoracic nerve had a branch, had divided into several branches. So sometimes it's very difficult to identify the nerve clearly. So here we usually use the lateral thoracic artery as the landmark for us to identify the long thoracic nerve. So let's watch the video to see how we scan the nerve. So at the cranial, at the cervical region, we put our transducer posterior to the sternocleidomastoid muscle. And then you can find the nerve emerge from the posterior aspect of the brachial plexus. And it will reach the supraclavicular level once it pierces the middle scalene. So at the supraclavicular level, you can find the nerve is deeper to the brachial plexus. And another landmark for you to recognize is the suprascapular nerve. And the long thoracic nerve is on top of the serratus anterior. So sometimes if you can locate the fascial plane of the serratus anterior, you can easily identify the nerve. But if you encounter patients with serratus anterior atrophy, you will find difficulty to find the nerve because lack of contrast. So if you move your transducer to the truncal region, and then the truncal region, the nerve becomes smaller. So we usually use the artery as a landmark, and then you can find the nerve course on top of the serratus anterior. So this is the article written by my friend Dr. Libasama, and she used high-resolution sonography to visualize the long thoracic nerve. The method for her to scan the nerve is the same like us. First, they look for the nerve inside the middle scalene, and then at the supraclavicular level, they use omohyoid suprascapular nerve to help locate the long thoracic nerve. So another muscular landmark for us to recognize is the posterior scalene muscle. So once you find the long thoracic nerve pierce the middle scalene, you would find the posterior scalene posterior to the long thoracic nerve. So why do we have to recognize this nerve? Because in patients with weaning scapula, the main cause is the injury to the long thoracic nerve. So we can use ultrasound to identify whether the nerve is swollen or not. So here, this is the nerve at the abnormal site. You can find the nerve is swollen compared with the normal site. So another nerve is the thoracodorsal nerve. Thoracodorsal nerve is the branch of the posterior core of the brachial plexus. As you can see, the nerve is on top of the latissimus dorsi. So we know the main function of the thoracodorsal nerve is to innervate the latissimus dorsi. So how to scan it? First, you have to let a patient open the axilla to expose the infraaxillary region. And then here you can find this is the serratus anterior, this is latissimus dorsi. Once you find the latissimus dorsi, you can locate the thoracodorsal nerve. The thoracodorsal nerve is besides the thoracodorsal artery. So you can use this way to help you identify where the thoracodorsal nerve is. And another important thing is if you want to check whether the nerve is swollen or not, sometimes we have to use long axis view to have the long axis of the nerve to see if there is a focal narrowing. And another important thing is when we scan those nerves, we have to use artery as a landmark. For the long thoracic nerve, we use the lateral thoracic artery. So we can scan this artery along the middle axillary line. And for the thoracodorsal nerve, the artery we used for locating the thoracodorsal nerve is the thoracodorsal artery, and it's also a branch of the axillary artery. So another nerve is the dorsal scapular nerve. Through this cadaveric picture, we know the dorsal scapular nerve innervate the levator scapula and the rhomboid muscle group. So just like we presented before, the dorsal scapular nerve is also a nerve pierce the middle scalene. Dorsal scapular nerve is the first branch of the C5 nerve root. So if you scan the cervical nerve root at the C5 or C6 level, you can see the dorsal scapular nerve emerge from the posterior aspects of the nerve root. And the location of the dorsal scapular nerve is cranial to the long thoracic nerve. So you can find the long thoracic nerve first from the caudal to cranial scanning. And then once you find the long thoracic nerve, you can sequentially identify the dorsal scapular nerve. So how to find the nerve? First, we place our transducer at the interscalene level. So once you see the C5 nerve root emerge from the intervertebral foramen, you can find the dorsal scapular nerve has already entered the middle scalene. So its location is between the C5 and the C6 nerve root. So once you move your transducer more distally, you can find that this nerve emerge from the posterior aspect of the middle scalene, and then enter the space between the levator scapula and the underlying muscle. So let's watch the video to see how we scan this nerve. First, we place our nerve posterior to the C5, and then you can find that the small nerve emerge from the posterior aspect of the cervical nerve root. And then it will enter the space underneath the levator scapula. So this is the way that we can use ultrasound to identify the dorsal scapular nerve at the cervical level. But we know the dorsal scapular nerve is a nerve that innervates the levator scapula and the rhomboid muscle group. So how can we locate the nerve at the posterior aspect of our trunk? First, we place our transducer medial to the scapular spine, medial to the middle scapular border. And then you can find that the most superficial layer of the muscle is the trapezius. So underneath it could be the rhomboid major or rhomboid minor. And then you can find the dorsal scapular artery underneath the rhomboid muscle group. And then you can see the intercostal muscle is between two ribs. So the dorsal scapular nerve will be seen besides the dorsal scapular artery. So once you see the nerve, you can pierce the transducer in long axis. Then you can highlight the nerve in its long axis. Because sometimes in patients with dorsal scapular nerve entrapment, we will use long axis view to hydrodissect nerve to relieve the symptom. So this is the image showing the vasculature near the scapula. As you can see, the dorsal scapular artery is the branch of the transverse cervical artery, and it will cross at the medial aspect of the scapula. So at the middle aspect of scapula, we can use the dorsal scapular artery as a landmark for us to recognize the correct fascial plane. And let's use ultrasound to scan the nerve. Yeah, this is the video. First, we place our transducer medial to the middle scapular spine, and then we can find the nerve medial to the dorsal scapular artery, and it is interposed between the rhomboid muscle group and the intercostal muscle or rib. So once you recognize this nerve, you can pierce the transducer in the long axis to follow this nerve. So this is the article written by Professor Stanley and my colleague, Dr. Hong and Dr. Su. And then this is the later to editor commenting the injection of dorsal scapular nerve entrapment. So here, as you can see, they provide a well-edited picture to elaborate the dorsal scapular nerve and the dorsal scapular artery. As you can see, the muscle at this region is quite complicated. For example, you can see if you put your transducer over the proximal region, you can find that the most superficial muscle is the trapezius, and the levator scapula will be underneath it. And then you can find the artery and the nerve will be beside it. And then move your distally, you can find that the size of the levator scapula is decreased, and then you can still find the consistent location of the dorsal scapular nerve against the dorsal scapular artery. So because the muscle at the region is very complicated, so in 2019, we wrote a later to article to describe how to scan the muscle that attach to the middle scapular border. So the muscle we are going to elaborate include the levator scapula, rhomboid minor, and the serratus anterior. So this is the cadaveric picture. In the cadaveric picture, you can identify this is the scapular spine, and this is the middle scapular border. This is the supraspinatus. This is the levator scapula. So here you can find that the course of levator scapula is actually quite vertical. So levator scapula emerge from the posterior aspect, from the posterior tubercle, and attach to the middle scapular border. So at the distal part, you can find that the levator scapula has already become a tendinous part. So if you check the muscle at the medial side, you can find two muscles. Another one is the rhomboid minor and the rhomboid major. So let's see the cross-section of cross-section image that pass through the middle scapular border. Here we can find this big muscle at the supraspinatus fossa is the supraspinatus. And this is the middle scapular border. And the structure medial to it is the levator scapula. Just like we presented before, the levator scapula will attach to the middle scapular angle, and the rhomboid minor will be middle to the levator scapula. And of course, the bigger muscle superficial to the levator scapula, and the rhomboid minor would be the upper or middle trapezius. And another muscle that is located anterior to the scapula is the serratus anterior. As you can see, the serratus anterior is actually very big. So here we can find if we put our transducer at the supraspinatus fossa, and then we let our transducer move medial to the middle scapular border, we can find that the most superficial layer is the trapezius, and the levator scapula will be underneath it. And the structure with a triangular shape, this is not the levator scapula, this is the serratus anterior. And the serratus posterior superior will be underneath the levator scapula and the serratus anterior. So how can we identify that this muscle is the serratus anterior? We can pivot our transducer to 90 degrees, and then we can find that the serratus anterior emerge from the anterior surface of the scapula and attach to the rib. So if we move our transducer more distally, we can find the size of the levator scapula decrease, and the size of rhomboid minor muscle increase. And then we can also find the serratus anterior muscle become smaller and smaller until we cannot identify it. and then move your transducer more distally, you can find that the levator scapula has become a tendon and attached to the middle scapular border, and the rhomboid minor muscle would be fully emerged from the undersurface of the levator scapula. So just like the name rhomboid means a quadrilateral shaped structure. So you can find that this muscle is shaped in a quadrilateral. It has a quadrilateral shape. So let's use dynamic image to identify which muscle you are scanning. So first, we put our transducer middle to the scapular border, middle scapular border, and then we change our transducer 90 degrees. And then you can find that the initially triangular shape serratus anterior will be seen in its long axis. So you can find that the muscle emerge from the anterior surface of the scapula and attach to the rib. So this is how we can confirm this muscle is serratus anterior instead of the levator scapula. And if we put our transducer more distally in the horizontal plane, first you can find the levator scapula. This is a rhomboid minor. And then you can find the size of the levator scapula become very smaller, and it's become a tendon attaching to the middle scapular border. And this is a rhomboid minor. And our dorsal scapular nerve will be underneath the rhomboid minor muscle. So another nerve we are going to cover is the intercostobrachial cutaneous nerve. This is the cutaneous nerve. So if you want to know how to scan those cutaneous nerve, you can refer to our article published in 2018. This article, we collaborate with the master of musculoskeletal ultrasound, Carlo Martinoni. And in this article, we also provide lots of videos so you can learn how to scan the cutaneous nerve by yourself. So let's look at this cadaveric picture. Here we can find the median nerve. This is the ulnar nerve, and the nerve posterior to, besides the ulnar nerve, is the medial antebrachial cutaneous nerve, and another nerve located, that is located more posteriorly, is the medial brachial cutaneous nerve. And the intercostobrachial cutaneous nerve would be, first you can see it's located underneath the pectoralis minor muscle, and then it will emerge from the second intercostal space, and then cross to the distal part on top of latissimus dorsi. So when we scan in the latissimus dorsi, can be our landmark to help us to identify the intercostobrachial cutaneous nerve. So how to locate those cutaneous nerve? First, you have to let the patient open the axilla and put your transducer at the middle posterior forearm. And then you can find the subcutaneous layer. You can locate two nerves. One is the medial antebrachial cutaneous nerve. The other is the medial brachial cutaneous nerve. The location of the medial antebrachial cutaneous nerve is anterior to the middle brachial cutaneous nerve, and it will cross besides the basilic vein. And then you can find if you move your transducer to the middle of the arm, and you can find that the medial brachial cutaneous nerve is located posterior to the ulnar nerve. So if we move our transducer on top of the latissimus dorsi, you can find the intercostobrachial cutaneous nerve is on top of latissimus dorsi. And then if you move your transducer more cranially, you can find the nerve will be on top of serratus anterior, and then will be submerged into the second intercostal space. So you may ask me why is it important to locate those cutaneous nerve? Let me provide a case. This case complains of pain over the arm and the forearm. So we use ultrasound, we can find that there is a lipoma on top of it, but underneath the lipoma is the medial antebrachial cutaneous nerve. So the patient usually complain of frequent electrical shocking sensation when we rub against her forearm. And also, we also identify another lipoma on top of the medial brachial cutaneous nerve. Likewise, if you compress this area, the patient would have the electric shocking sensation. So because those cutaneous nerve is very superficial. So besides, we can use this nerve for local local anesthesia. And then another important thing is if there is a space occupied lesion besides it, it could be compressed and cause symptom. So the last part is the suprascapular nerve. So the suprascapular nerve, traditionally we use when we scan it at the supraspinatus fossa. So at the supraspinatus fossa, we can find that the suprascapular nerve is underneath the deep fascia of the supraspinatus. And this image is published in American Journal of Physical Medicine and Rehab. And this article, this image has been chosen as the cover page of this issue. So, but we know the suprascapular nerve is the branch of the brachial plexus. So its location, just like what Professor Kamak has already presented, is located posterior to the brachial plexus. And we can use the omohyoid as a landmark to see the nerve underneath the omohyoid. So as a PMR physician, we also want to know whether the nerve would change in certain kind of patients. So in 2018, we performed a clinical study to evaluate the size of the suprascapular nerve at a different region. So in our study, we find when we measure the cross-sectional area of suprascapular nerve, we find that the cross-sectional area of the nerve at the distal part is larger than that at the proximal part. So we go back to see the categorical image. We find that because at the distal part, the nerve started to give several branches. So if we include all the branches together, we can find the size of the nerve at the distal part is larger at its proximal part. So what is the implication of this study? If you want to use ultrasound image to diagnose the patient to have suprascapular nerve neuropathy, you have to use a different standard value when you scan the nerve at the different sites. So later we apply this technique for patients for aging patients with shoulder pain. Again, we use the same technique to locate the suprascapular nerve at the brachial plexus level, the level of the supraspinatus fossa, and the level of the infraspinatus fossa. So we measure the cross-section. And in our study, we find that in aging population, we can find at the supraspinatus fossa. In patients with supraspinatus floor thickness tear, we can find that the nerve cross-sectional area is larger than those without the floor thickness tear. So here, let's look at the ultrasound image. This is the image from a person without the supraspinatus tendon floor thickness tear. This is image from another person with supraspinatus floor thickness tear. As we can see, in this patient, the supraspinatus muscle become atrophic, and the size of the suprascapular nerve is enlarged. So we propose a theory. We think in the aging population, they may suffer from muscle degeneration, so-called sarcopenia. And those patients would have shoulder impingement easily. And then eventually they would have a tear of the rotator cuff tendon. So once the tendon or muscle is torn, the torn muscle with the pull will retract the nerve to the medial aspect and cause nerve entrapment, and then the patient with neuropathy and the subsequent shoulder pain. So we know the suprascapular nerve is a great procedure for us to treat recalcitrant shoulder pain. So in our meta-analysis, we probe the issue whether the suprascapular nerve block is effective for the chronic shoulder pain. So this is the traditional way to perform the suprascapular nerve block. We block the nerve at the supraspinatus fossa. So we can find that using the suprascapular nerve block, the effect is better than physical therapy only and the placebo injection for the treatment of chronic shoulder pain. And it has equivalent effect to the intra-articular corticosteroid injection. And for patients who receive surgery, shoulder surgery, we also find that using the suprascapular nerve block can reduce postoperative shoulder pain, and also reduce the amount of opioid use, because the overuse of opioids would cause the postoperative nausea. So we can find using the suprascapular nerve block can reduce the postoperative nausea. And we also apply the proximal suprascapular nerve block technique for patients with malignancy associated shoulder pain. And we find that most of patients had good response. But if you want to use a proximal suprascapular nerve block, the dose of the block is something that we have to consider. So in this regard, we wrote a letter to article commenting an article comparing the proximal and the distal suprascapular nerve block. Because from this picture, we can find the brachial plexus and the long thoracic nerve is very close to the suprascapular nerve when we block the nerve at its proximal region. So in this sense, if you want to block the suprascapular nerve at the proximal region, it's better to use small volume. For example, 2 to 4 milliliter of lidocaine would be suitable. Okay, thank you very much. If you are interested in my talk, you can refer to the MSK Ultrasound Club in Facebook. There are so many experts join this forum, and you are welcome to join it. Thank you very much.